Occupational therapy process for osteogenesis imperfecta. Michael, a case study. For Kaiser University for Myers, MSOC Cohort 3, I'm Jorge Castillo.
And Juan Ramos.
Michael is a 7-year-old boy who was admitted to the hospital after experiencing multiple fractures over the last year. His parents report that he mostly keeps to himself and doesn't like to participate in play and leisure activities with family or peers. His mother states that most of the fractures have happened when he is playing by himself, but she has never seen him take a hard fall. Previous fractures have been treated with fixation devices, and he didn't complain of additional pain or muscle weakness after recovery. Physical exams show that Michael has also gained weight in the past year. He has had 3 fractures. He slipped from a short stool during a group activity in class and fell to the floor, landing on his left arm. He complained that he had hurt his hand when pushing against a heavy door that wouldn't open at school, and he fractured an elbow playing hide and seek while he was trying to climb inside a treehouse at home. When admitted, Michael's attending physician noticed blue sclera in his eyes, as well as teeth that appeared damaged. When completing the physical exam, the doctor noticed that Michael has hypermobility along his joints. He also noticed that the x-rays evidenced low bone density around the skull. Michael was officially diagnosed with type 1 osteogenesis imperfecta, or OI, also known as brittle bone disease, which is a form of hereditary bone fragility that can severely affect the quality of life of the individuals. The type 1 classification signifies that the condition is mild and most likely non-deforming. There are several types of OI, ranging from mild to severe to life-threatening, and within the population of individuals with OI, Michael got lucky.
A diagnosis of OI doesn't have to be a death sentence, but it does affect the quality of life of the individual to a significant degree, depending upon the severity. In some cases, certain motor skills may simply be impossible due to skeletal deformities, muscular weakness, or other factors. As infants develop through childhood, certain reflexes and skills are first developed that go on to serve as building blocks for life. For example, a child must first develop gross motor skills like reaching and sitting before they're able to stand up and start moving around. These skills may be delayed for children with OI or difficult to integrate successfully on more severe types. Mike was fortunate that his symptoms have mostly gone unnoticed until now because he doesn't participate in play and leisure occupations as much. If he had, he would have been falling down and hurting himself with much more frequency. When children don't move as much, they also don't burn as many calories, so they gain weight. Michael demonstrates joint hypermobility and stress across the joints as a result of his weight gain over the last few years. Michael is largely independent in most activities of daily living and is successful academically, his lowest grade being PE, and his mother has already provided the school with a doctor's note to excuse him. He doesn't require assistance for any hygiene tasks, can bathe and dress independently, and mostly requires to be more careful around the house. An ongoing concern, however, is that every task takes a long time for him to complete, as he can become easily fatigued. Overall, children with OI demonstrate decreased endurance across some occupations, and this might be a reason why Michael doesn't enjoy participating in leisure and play activities. Michael does have a good support system at home, with parental involvement driving the search for a diagnosis. His strengths far outnumber the areas of concern, and his family consider themselves lucky that this is the case.
Osteogenesis imperfecta is a form of inherited bone fragility that can severely affect the quality of life of the individual. The name literally means imperfect bone formation, and it is commonly referred to as brittle bone disease as a result of its symptoms. A child born with this condition is likely to have soft bones that fracture easily or that didn't form correctly. The milder forms are characterized by bone fractures as a result of minor trauma, like children who injure themselves while learning to walk. As they reach adulthood, the incidence of fractures decreases, but it is still an ongoing concern. Some of the extra deficits associated with OI include hearing loss, which is observed in over 50% of adults with OI by the time they reach 50 years of age, as well as in 5% of children. Small, discolored, and deformed teeth can also be seen, usually caused by a condition called dentinogenesis imperfecta that affects tooth development. Blue or gray sclera is noticed in the eyes. Joint dislocation can be caused by connective tissue abnormalities. Kidney stone disease can also happen as a result of elevated calcium in the urine, and aortic root dilation and mitral valve prolapse can happen as a result of cardiovascular involvement in the condition. As a result of these factors, individuals with OI require exercise and recreational activities that are tailored to their needs and fragile bones. Although fractures are typically less common in adulthood, rheumatoid arthritis and osteoporosis are ongoing concerns as they age, so continued care is required throughout their lives. Weight-bearing activities would be a great addition to any exercise program, and the inclusion of low-impact activities like swimming could also be beneficial as long as precautions are observed. For those who may have increased pain from the condition, safe handling during transfers and moving into different postures throughout the day may help prevent deformities and strengthen muscle groups.
Using a model of practice within our professional setting helps us to analyze a client's deficits while using occupation-centered interventions to enhance their growth. It allows us to closely observe the occupations a child engages in and provides us with a way to intervene at many levels along the developmental cycle. Similarly, a frame of reference provides us with specific techniques to employ in therapy, as well as strategies for interventions based on theoretical principles that guide the profession. For Michael, a good model would be SCOPE IT, or the synthesis of child, occupational, performance, and environmental in-time model. Hardy describes how the model focuses on the child's growth and engagement in occupations throughout development in order to enhance occupational performance. This model analyzes each client using both a top-down and bottom-up approach, with particular focus placed on occupational engagement, performance components, as well as environmental factors affecting the performance at that developmental stage. By identifying strengths, barriers, and motivational factors across the areas of occupation, this model emphasizes a holistic approach that underlines the child's environment-occupation relationship. In order to enhance therapeutic interventions with techniques and strategies relevant to Michael's condition, the frame of reference for motor skill acquisition would be ideally employed to enhance therapeutic interventions with techniques and strategies relevant to his condition. Kaplan explains how the FRMSA focuses on the child's abilities to carry out a given task, including how the task itself affects their engagement and the skills required to undertake it. It also emphasizes the role of regulatory conditions as aspects of the environment that affect specific movements. With this frame of reference, the child is centered around task and environment, and their interaction is what fuels any given outcome. Therapists gather this information and act as facilitators to structure learning activities that promote their ability to perform other tasks, such as age-appropriate occupations involving school. In Michael's case, his lack of endurance and how it is affecting his occupational performance could be viewed through the lens of this model.
Although Michael may not need them, adaptive equipment can be an instrumental tool for individuals with OI. Depending on the severity of their condition, they may require a variety of mobility aids to ambulate and participate in their environment. Canes, walkers, and wheelchairs may be used by individuals with OI to improve the quality of their ambulation and decrease fatigue and lack of endurance. Environmental adaptations may also be made at home, school, or at the workplace to address any specific concerns inherent to their occupational performance in these settings. The biggest obstacle to independent function for individuals with OI is fear. They are afraid of falling down, of hurting themselves inadvertently, and most of all, they're afraid of not being able to enjoy their lives and take part in it. Providing support to people with OI, helping them overcome weakness, educating them on how to prevent injury, and helping them lead successful independent lives can all be achieved through skilled intervention. Occupational therapy, with its client-centered approach to evidence-based practice, is best positioned to provide this care.